Hello, my name is Michelle Kosick. Welcome to the workshop, Safeguarding Your Health from Late Complications After a Transplant Using Donor Cells. I'd like to thank Pharmacyclics and AbbVie Company, Janssen Biotech Incorporated, and Gamida-Cell, whose support helped make this workshop possible. It is my extreme pleasure to introduce Dr. Minoo Battiwalla. Dr. Battiwalla is a stem cell transplant physician at the Transplant and Cellular Therapy Program at TriStar Centennial Medical Center in Nashville, Tennessee. He is also the Director for Outcomes Research and leads the Survivorship Program for the Sarah Blood Cancer Network. Dr. Battiwalla chairs the Steering Committee Chair of the National Institutes of Health Late Effects Initiative and co-chairs the Cardiovascular and Metabolic Committee. He is a well-known expert on the topic of late effects after stem cell transplantation and has published extensively on the topic. Please give me a warm welcome in welcoming Dr. Battiwalla.
Thank you very much for that introduction, Michelle. I want to welcome the 1,800 global registrants from 28 countries to this conference to celebrate a second chance at life. Safeguarding your health after an allogeneic transplant, which is a transplant from a donor, is going to be the focus of my talk. I consider survivorship the scientific art of maximizing health after cancer treatments. And it is my distinct privilege to be able to speak to you today. I have no financial disclosures to make. So what I will discuss today are long-term and late survivorship issues in allogeneic stem cell transplantation. Why are we talking about this today? Because cure is not enough. And there's a growing emphasis on the quality and not just the sheer quantity of survivorship after these sort of transplant treatments. It is important to understand when problems occur because they occur in very unique time frames, and complications which occur in the first few months may never pop up again, whereas entirely different complications could happen years and even decades after the transplant. It is important to be aware of the broad spectrum of the health problems that our transplant survivors may face. Some of them are also potentially lethal, so it's important to recognize them early. And huge challenge is how do we effectively deliver care to our survivors in a timely fashion, especially when they are geographically distributed, sometimes many miles and different states from the original transplant center. So I want to touch upon all of this today. So as you know, the field of stem cell transplantation has been rapidly growing. Over the years, there has been a massive increase in transplantation because of growing efficacy, more safety. So more patients are surviving and are living longer. And this justifies a shifted emphasis towards protecting and safeguarding your health. By one calculation, in 2020, we had about 250,000 transplant survivors. And by 2030, we should easily double that number. 60% of transplant survivors are autologous transplant recipients, and 40% are allogeneic, the focus of today's talk. And 60% are aged between 18 to 59, but that also leaves at the tails a large number of very young individuals and much older individuals, both of whom have special needs. Now, if you look at the graphic on the right, you will notice in the top panel, the number of survivors is rapidly growing. And if you look at the graphic at the bottom, over time, post-transplant, especially when the transplant is done for blood cancer. The risk of relapse diminishes over time. So as time goes on, there's a very high likelihood of cure. On the other hand, we have an overlapping population with growing health problems, and these can impact the quality of survivorship. And consequently, we can only wish that all our transplant survivors are as fit, healthy, happy, and youthful as the participants in a reality TV show. But that is often not the case. Survivorship might give you a cure, but it might come at a tremendous cost. Consider that about 40% of childhood cancer survivors have severe illnesses or might even die of such illnesses. 80% of transplant recipients will have one or more late effects at 5 years after transplant. And even if you're cured, the 5-year life expectancy is significantly lower than a comparable general healthy population. And, we have this conundrum shown in the middle graphic, where you have a sick patient who transforms into a possibly vulnerable survivor with that sword of Damocles always looming over one's future. So how can one deal with this? So it's important to recognize the spectrum of problems. Long-term and late effects impact all domains of health. While the focus is primarily physical, on all the physical problems that you can have, but one should understand that a holistic view of health includes consideration of sexual, emotional, psychosocial, as well as the impacts of financial toxicity. You may ask, why do long-term and late effects occur? There are basically 3 reasons. The first reason is, of course, there's this toxicity from the conditioning regimen, the chemo or the radiation that you may have received. And this is, of course, piling on top of all the other cancer treatments you may have received before the transplant. A second consideration is an overlap with pre-transplants or an individual's genetic predisposition to getting some problems, including their prior general health. And last, and what is unique to the allogeneic transplant setting, is the impact of immune dysregulation, particularly chronic graft versus host disease, which, as we shall see later, accelerates all the late effects that we expect to see after the transplant. From the transplant physician standpoint, we can mentally visualize distinct but variable timeframes for complications. In the first few years after the transplant, typically first 3 years after the transplant, our focus as physicians is on treating graft versus host disease, both acute and chronic graft versus host disease, which burn out over time. There's also the risk of early infections and the risk of malignancy recurring. But over time, these will fade away. And then you have a different set of complications. And some of them are shown here, impact on thyroid hormones as well as other hormonal problems, fertility, bone loss, eye problems, lung problems, cardiovascular problems, and new malignancies. And these have variable times of onset. Sometimes the risk continues to increase over time, as we expect even with general aging. And then for very long-term survivors, maybe 20, 30 years and beyond, there are many questions which are left unanswered. Will there be stem cell exhaustion? Will there be accelerated aging in general? could there be neurodegeneration? We don't know the answers to all these questions, but these are areas of intense research. Today for you, I would like to give you a focus on some of the key late effects as I see them in our patients. The box on the left shows potentially lethal late effects, which are largely preventable, but you need to know about them in order to prevent them. Infections, second cancers, heart and vascular issues, and lung problems. At the minimum, you should pay a lot of attention to these. And then on the right-hand graphic, you will see non-lethal but problematic problems. So issues such as endocrine and metabolic, and we'll discuss some of these, bone health, sexuality, fertility, iron overload, impact on general health, brain problems such as chemo brain, and mental and emotional problems. Graft versus host disease is like that inflammatory background fire which fuels all of these and exacerbates all these problems. So I will first focus on some of the key late effects which could possibly impact survival. Infections are always treatable and almost definitely preventable in many cases, and it is a shame that patients continue to lose their lives after infection, after an allogeneic transplant. Bearing in mind that the key point in their immune deficiency is very early post-transplant. So a lethal infectious complication many years later is clearly preventable. So this study from the International Transplant Registry shows that if you survived more than 2 years after transplant, you are still at risk for infections for over the next 10 years. And yes, adults have it worse than children. And what are the causes of these late fatal infections? They're surprisingly not the typical opportunistic infections. They are all the common infections: bacterial, fungal, viral, and multiple infections. So what can we do about it? Well, infections can easily be prevented, and all our transplant patients after are on these prophylactic or preventative antimicrobials. These can be antifungals like the azoles, antivirals like acyclovir, anti-PCP and toxoplasma drugs such as Bactrim, and antibacterial penicillins for some patients who have chronic graft versus host disease. I often find that patients will prematurely stop these prophylactic drugs. These often need to be taken for at least months and sometimes many years after a transplant. They are very safe for the long run and can give us a huge umbrella of safety. The next strategy is vaccination. The allogeneic transplant will wipe out your immunologic memory against all the childhood diseases, and you will need to resume all your childhood shots. So the key point is not if to give it, it has to be done. The key point is when to start. The strongest data is for protection from COVID and influenza by vaccination. And here, perfection is the enemy of the good. And the general recommendation is, regardless of whether or not you're on immunosuppression, at 3 months after the transplant, you should start getting COVID and flu shots. Whereas you have the luxury of time to wait for at least 6 months after the transplant and being off systemic immunosuppression before starting all the other routine childhood vaccines. I will now focus on second cancers or subsequent neoplasms. There is a threefold higher risk of another cancer after transplant. And the graphic shows that stem cell transplant survivors have far higher rates of second cancers compared to what is expected for untransplanted population for their age. So this can be an entirely different cancer. It's related to cumulative doses of all the chemotherapy and radiation that the survivor has received. And these can unfortunately occur with a latency of a decade or longer. And this can happen long after you have severed your connection with the transplant center and hopefully outlived your transplant physicians. So how do we manage this? Well, prevention, prevention, prevention. These are strong recommendations for our transplant survivors. Skin is the most vulnerable organ. And I can personally attest to a patient of mine who was a truck driver who did not believe in sun protection and would drive with one arm outside his cab and with the other arm inside. I personally had to remove 17 skin malignancies from the arm which was dangling outside the cab, exposed to the sun, versus none on the arm which was protected. Our patients need annual dermatologic skin exams, even if you do not reside in a sun belt. Sunscreen is your friend. Please use broad spectrum sunscreen, which covers both UVA as well as UVB, with a very high SPF, a minimum of 30. Avoid peak sun, wear sunglasses, hats, and sun protective clothing. Trips to the beach are certainly possible if you follow these sort of guidelines. Thyroid cancer just requires an annual physical examination. Mouth and throat cancers are also very common, and this is the primary reason you need to have a dental exam at least every 6 months. Not so much as to keep your teeth healthy, but also to look for oral cancers. HPV vaccination greatly reduces the risk of oral cancers, and that is part of the vaccination strategy. The lungs are one of your most vulnerable organs, and if you've ever been a tobacco smoker or user or vapor, you have to stop it. It's a big no-no after transplants. There are recommendations derived from the general population for using low-dose screening CAT scans for high-risk patients. The breasts are a vulnerable organ, especially if you have received radiation for any reason. So there are recommendations for clinical breast examination, mammography, and occasionally MRI based upon your transplant characteristics. Gynecologic cancers, particularly cervical dysplasia, is often triggered by a rampant human papillomavirus. The annual HPV testing and HPV vaccination should be performed as part of an annual gynecologic examination, even if you are postmenopausal. Esophageal screening is only if you have difficulty swallowing, and all people over the age of 45 to 50 will need colorectal cancer screening, whether you've had a transplant or not. Hopefully, stringent adherence to these preventable conditions will make a big difference in allowing you to live a longer and healthy life. And I want to talk about cardiac and blood vessel issues. There are 3 groups of problems affecting our transplant survivors here. The first is cardiac dysfunction, which is a pump failure where the heart fails to pump well. This is typically seen in the younger population and those who have received certain kinds of drugs, chemo drugs and or radiation. Arterial disease is linked to underlying inflammation, and it can happen in the coronary vessels leading to premature heart attacks, but also in the vessels which feed the brain, leading to early strokes, and of course, peripheral vascular disease. And then potentiating all this are metabolic disorders, which are also increased in our transplant population, with a threefold higher risks in hypertension, diabetes, cholesterol problems, and obesity. So understand that all of these result in a cumulative risk of future cardiovascular events, which are much higher than the general population. The events will occur earlier. According to one study, the first heart attack occurred 14 years earlier than the general population. This risk is permanent and tends to increase with time after transplant. So how do we prevent this? Well, screening. Once things are stabilized at 6 months to 12 months after transplant, you need to start screening for all the preventable cardiac risk factors. Correct blood pressure, cholesterol, diabetes, overweight, smoking, and in select cases we will do echocardiograms, and in people who are vulnerable, we'll also be taking a closer look at your heart with EKGs and stress testing and CT angiograms. The next vulnerable organ is your lung. Please, 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 if you have not heard it before, stop all smoking or vaping. And infections are a common problem here. Get vaccinated and seek medical attention early if you have any pulmonary symptoms. Although graft versus host disease is going to be covered extensively in another workshop, I want to emphasize that lung injury from graft versus host disease is the killer form of chronic graft versus host disease. I want to emphasize that it is frequently misdiagnosed, even by transplant doctors and professionals, as infections or pneumonias. So it is often recognized at a point where it is too late. There are two patterns of lung GVHD. One is cryptogenic organizing pneumonia, which occurs early. It resembles infectious pneumonia in terms of presenting with fever and cough and breathlessness, and will show up with infiltrates on a CAT scan, but it is not an infection. And after rapidly ruling out infection, it is very easily treated with steroids, but for a long course of treatment. On the other hand, a different form of lung GVHD, which affects the airways, is called bronchiolitis obliterans. This is silent early, and by the time symptoms occur, too much damage has been done, and it is absolutely irreversible at that point. This is why, if there is any evidence of chronic graft versus host disease, we recommend serial pulmonary function testing every 3 months for the first 5 years. If you don't have graft versus host disease, then serial pulmonary function testing should be performed every 6 to 12 months. Now we'll move on to some of the non-lethal problems which consume a lot of our attention. Bone damage is common. It takes two patterns. The first on the left is a loss of bone mineral density. You've heard of terms like osteoporosis, which is the higher grade, and osteopenia, which is a lower grade. And the normal bone will appear hollowed out. This is often treated with vitamin D, calcium, exercise, etc., etc. Avascular necrosis is a different pattern. It presents with severe pain and joint fractures because the bone underneath the cartilage dies. And if you look at the graphic, you'll see that the regular smooth contour has been replaced with an irregular contour with bone rubbing against bone. It is severely painful and ends up requiring joint replacements. Endocrine, hormonal, and metabolic issues are very common. Low levels of thyroid hormones are very common, and most patients will end up requiring, or I shouldn't say most, but many patients will end up requiring lifelong supplementation. threefold higher risk of diabetes, high cholesterol. Sex hormones are universally diminished, resulting in premature ovarian failure. This can, of course, impact sexuality, but can also give you fatigue. There can be genitourinary changes, especially vaginal changes and pain, and symptoms of premature menopause. Men will suffer from erectile dysfunction and loss of libido. Infertility is very common, but may be avoided if you have received a very reduced intensity transplant. So what do we do about it? For ovarian failure, I strongly recommend hormone replacement therapy up to the age of natural menopause. Whereas for men, they will all have low testosterone, and in my experience, testosterone supplementation really does not provide any clinical benefit. There are many other general health issues which persist for a long time, and here are some tips. Fatigue is common, so try and identify the underlying medical cause. Need to treat pain, reduce workload to part-time, exercising to build up strength and endurance, and strategic naps to recharge your batteries. Sleep disturbance is also very common, and cognitive behavioral therapy might help. Sleep hygiene is also important. Muscle cramping is a common issue, and hydration and tonic water can help. There are mental health challenges. A very unique issue in many malignancy survivors, particularly transplant survivors, is a sort of fogginess in the brain. It is colloquially referred to as chemo brain, and it is characterized by short-term memory loss, reduced thinking, word-finding difficulties, a slight diminution in executive function. It can improve, but might take a year to 5 years after the transplant. There's cognitive rehab, and certain medications might help, but this requires the guidance of a competent neurologist. Eyes are very commonly affected. Dry eyes and premature cataracts demand annual eye examinations, and lots of things can be done about them. The mouth is also an area for attention. Dry mouth, cavities, risk of oral malignancies require regular dental examinations. Kidney, you should have an annual urine protein check. Protect your liver by avoiding alcohol. Iron overload from cumulative blood transfusions will sometimes require phlebotomy, that is a little bit of bloodletting, till the iron levels come down in the body. Neuropathy is related to cumulative chemotherapy. It's important to see a neurologist and get good foot care. There are some medications for neuropathy, and the pain and discomfort does diminish over time. There is scope for improvement. So my recommendation for all our patients is to adopt a healthy lifestyle. Many patients ask about diet, and a healthy, balanced diet, including at least 5 daily servings of fruits and vegetables, is important. Multivitamins, please avoid iron, and aggressive supplementation of calcium and vitamin D where indicated. These will help with diabetes, weight, osteoporosis, cholesterol, as well as your heart health. Exercise is important, not just for weight reduction, but because weight bearing builds up your bones and reduces the risk of osteoporosis. I also strongly recommend stretching or yoga exercises because stiffness of the joints is exceedingly common. And you must get at least one exercise session every day. These help with your bones, with fatigue, with your brain, and your flexibility. Infections, get used to hand washing and using a little hand sanitizing wipe all the time. Sleep hygiene is important and can help with your overall fatigue. For habits, stop smoking, stop nicotine, moderate your alcohol intake, and please establish lifelong specialist care, gynecologist, dental, eye, and skin. So how do we bring it all together? We know that simple screening and prevention can greatly improve survivor health. And we at Sarah Cannon, across our blood cancer network, have addressed the special needs of our survivors by creating a dedicated survivorship clinic. Many transplant centers will also have models such as ours. At our center, at the heart of coordinating all of this is a dedicated long-term follow-up transplant coordinator who will take information from the primary care physicians, from consultants, and coordinate visits with the transplant physicians as well as the transplant nurse practitioner. The transplant physicians tend to focus on the acute critical issues, and they will focus on cancer control, graft versus host disease, sometimes infections, and these will be routine visits as clinically indicated. Whereas our survivorship nurse practitioner or physician assistant will focus on milestone visits. And these are very long visits, taking at least an hour to conduct. And we conduct these milestone visits at day 100, 6 months, and annually, and integrate information from all the consultants that you see. And we then sit together as a group and provide final recommendations. This is obviously extremely laborious and not a model that is available to many many transplant survivors, some of whom might be present on this call. So if you are a transplant survivor and you do not have access to a survivorship clinic, what can you do? Well, one solution, which is being rapidly adopted in our transplant field, is individualized survivorship care plans. And this is a relatively recent development in the field. These are, this is a document, and we give it to our patients to carry home with them as a passport to take to their referring physicians, to their consultants, and when they return home. And it's something as an enduring document, and we give it at day 100 and update it from time to time. So this document lists the transplant therapy they received, the chemo, the radiation, did they get GVHD, how was it prevented, did GVHD occur, and recommends treatments which are based upon the patient's age, their chemo, whether or not they got radiation, and their sex. So this is another way you can protect your health without having to attend a survivorship clinic. And yes, this is complicated, but you are not alone. There are many organizations which seek to help, such as the organization which has created this symposium. Another good source for documentation and help is the National Marrow Donor Program, which is now known as Be the Match. They have a very active survivorship support program, which they administer via phone app, website, as well as telephone support. So the link will be available to you. So in conclusion, late effects are common and frequent. You must commit to long-term follow-up. Multidisciplinary care is complicated but meaningful, and survivorship clinics and individual survivorship care plans are really helpful. Please take responsibility for your health, practice good health, know your treatment, understand the complications you have endured, be aware of future risks, and ask questions. So what I've provided was an overview of survivorship after allogeneic transplant. There are other workshops covering individual organ systems and problems as part of our symposium. Please make a note of these and feel free to attend the ones which are very relevant to you. And there is also an entirely different set of programs devoted to graft versus host disease, which, as I've alluded to, really accelerates and aggravates all the problems that we see. So with that, I will end the didactic portion of this talk. I will be very happy to take your questions. Once again, I'm absolutely amazed at the journey and the courage that our survivors show, and I want to wish you all the best. Thank you.
Incredible presentation. Thank you, Dr. Battiwalla, for all of this information. I know we've got a plethora of questions for you. So we're now going to go ahead and move to the question portion. As a reminder, if you have a question, please go ahead and type it into the chat box on the lower left-hand corner of your screen. Our first question is, do we have any knowledge if any specific vaccines would lead to an increased risk of graft versus host status post-allogeneic transplant?
There is absolutely no evidence, even anecdotal, that vaccinations incite, aggravate, or worsen graft versus host disease. Instead, the preponderance of evidence suggests that vaccination saves lives and should be given.
Thank you. Our next question is, are there certain chemotherapies that are linked to an increased risk of cardiac dysfunction?
Yes. Radiation, if used as part of the transplant, and the group of chemotherapy drugs called anthracyclines, and a specific alkylating agent named cyclophosphamide can cause heart problems.
Thank you. Oh, this is a great question. Do you recommend getting Shingrix vaccine before discontinuing the use of acyclovir?
Yes, in our practice, we overlap acyclovir till both doses of the Shingrix vaccine are given.
Terrific.
Absolutely, I think this is a terrific practice. I would never stop the acyclovir unless I have both doses of Shingrix under the belt.
Excellent. The lung injuries with graft versus host disease you are describing in your presentation, they are both non-infectious, correct?
Absolutely. These are non-infectious, inflammatory reactions induced by donor immune cells directly or indirectly attacking different parts of the lung. But yes, they do look like infections.
Exactly. The next question is, when you mention diabetes, are you speaking of type 1 or type 2?
Very good question. The type of diabetes that we see after transplant is exclusively type 2 diabetes. That is where there's insulin resistance. And it kind of goes together with many other metabolic issues. Type 1 diabetes refers to reduced production of insulin from a destroyed pancreas. That is not what we see after a transplant.
We have a very smart audience. I got to tell you, I'm reading some of these questions, Dr. Battiwalla, and they're pretty incredible. What is the reduced intensity transplant, and when is it indicated? What are the risks versus benefits? But this is a long one, so I'm going to have you, let's just talk about what a reduced intensity transplant is first, and when is it indicated, and then I can continue on with the rest of the questions.
Um, well, the choice of transplant conditioning regimen should be left to your transplant physician. That's something I strongly believe. We can use higher intensity regimens in patients who are younger, who have an aggressive disease, which would require such intensity. For patients who are either older or who have comorbidities, such as, let us say, a bad heart or lungs, or maybe having a second transplant, or have a disease which is not that aggressive, we could get away with a reduced intensity transplant. Often the choice is forced on us because of considerations such as age and disease. The benefit of a reduced intensity transplant is that there is less chemo or radiation used, and there are fewer side effects. However, the usual downside of using reduced intensity conditioning is that there is a potentially higher risk of relapse of malignancy. So it is a complicated calculation which transplant centers will use to determine what is the best conditioning regimen for you.
Wonderful. There is another question that asks if all women end up on hormone replacement therapy, and I believe your recommendation was that you strongly recommended it. Do you want to take that a little further?
Yes. So all women who are below the age of natural menopause, which in the United States is early 50s, deserve to get hormone replacement therapy for the following reasons. One is that it mimics your natural body hormonal status up to that point. Second, it protects your bones and your heart. I can't emphasize this enough. There's a lot of data that suggests that hormone replacement protects your heart health. There are side effects from hormone replacement, and if you would not qualify for hormone replacement therapy for reasons such as a tendency towards blood clotting or other very rare syndromes, then maybe you may have to skip that. But otherwise, I strongly believe it's the most healthy thing we can do to maintain the health of our female survivors. But it's also important to stop it at the age of natural menopause.
Oh, I like this question. Can you speak about the newly approved graft versus host disease drug, Rezurock?
That's a complicated question, and I will say that we've gone from an era where we had nothing but steroids, which seemed to help and the standard GVHD drugs like tacrolimus, cyclosporin, which were used for treatment of chronic graft versus host disease, to now we have 3 FDA-approved drugs, Imbruvica, which is ibrutinib, Jakafi, which is ruxolitinib, and Rezurock, which is belmosudil. All of these probably have a benefit in chronic graft versus host disease. Rezurock is somewhat interesting because it acts by a different mechanism than the other agents, and in my anecdotal experience, may help with some of the more stubborn forms of chronic graft versus host disease. I think the primary benefit from all 3 of these newly approved drugs is that it gives us the confidence to avoid using steroids long term, which is a huge problem for our patients.
Thank you. Is the sensation of a tight band around your chest an indication of possible lung graft versus host disease?
I actually have 2 patients currently who have that sensation, And no, it could be skin graft versus host disease occurring really as a tight sclerodermatous band around the chest. We have seen that very often. Yes, anything inside the lung might potentially give you that sort of feeling. Neurologic problems from spinal compression, let us say osteoporotic spinal fracture, could also give you a band sensation. So this is there are clearly many possibilities here which deserve medical attention. Please bring this to the attention of your physician.
Our next question is, what causes iron overload?
Iron overload in our patients is typically related to either excessive red cell transfusions. Each unit of red cells that you have been transfused contains about 50 milligrams of iron. In contrast, and which is delivered directly into your bloodstream. In contrast, every day that you eat, even if you eat a regular diet with red meat, you get about 1 to 2 milligrams of iron. Over time, if you get 20 to 30 units of red cells with every transplant, you're likely to get heavily iron overloaded. This can cause some problems, health problems, which is why at around 3 to 6 months after transplant, many centers will measure your iron levels and determine if a little bit of bloodletting called phlebotomy will help rapidly bring your iron levels under control. So transfusional iron overload is the commonest cause of excessive iron buildup in your body. And of course, there are genetic syndromes like hemochromatosis, etc. And if those occur in conjunction with transfusional iron overload, that can be really quite serious. But most patients will not have that. Very interesting question. Oh yes, the other corollary to all of this is that if you have iron overload, it's important not to take many forms of multivitamins, which also have iron supplementation. So we usually recommend avoiding the women's health vitamins, which all have iron, and going for the men's health vitamins, which lack iron.
That's really important. Thank you for that addition. One of our questions is, I have chronic graft versus host of the eyes and mouth. I had a PFT at the 2-year mark, currently at 4.5 years, trying to wean off spinal immunosuppressant. How often should PFT tests be performed on me?
Very good question. If your immunosuppression is being weaned off, it means that your chronic GVHD is slowly burning out. It is very unlikely that you will develop new areas of chronic graft versus host disease. So I would suggest, continuing doing 3 monthly lung function tests up to about 5 years after the transplant, and then switching to maybe 6 months for another year or two, and then stopping altogether if everything looks good.
Our next question is, are secondary cancers influenced by the original cancer treated with BMT? In other words, are second cancers more common on survivors who had a specific cancer type?
Generally not. I'm sorry, I can't give you a more specific answer than that. But there's a lot of interest in how these cancers arise. It's a confluence of either your genetic predisposition, which gave you the first cancer in the first place, then all the chemo and radiation and other toxic treatments you have received, then combined with the inflammatory environment of graft versus host disease, immunodeficiencies which allow certain oncogenic viruses like HPV to thrive, and all of these are, act together and can tickle the genome of your, of normal tissue and drive additional cancers.
Wonderful. How do you mentally deal with the constant setbacks? I seem to be in a cycle of one step forward and two steps back. It's hard for me to stay positive all the time.
Congratulations, you are a great dancer of the transplant tango. One step forward, it's two steps forward, one step back. But the important thing is the next is that you are moving forward. As time goes on, a lot of these problems will just cease to exist and the risk will completely fade away. So I've had patients who have fought for their lives and have ultimately gone on to run marathons. So improvement, as long as the general tendency is positive, is worth fighting for because a lot of these problems are often solvable and will improve with time. So my recommendation is have a sense of optimism, have trust in your healthcare providers, seek the attention that you need. Some of these treatments are going to be prolonged, but the future will be bright.
And I think psychosocial team within your transplant team can also be a wonderful, wonderful asset to help support our patients. For cramping,
Absolutely.
For muscle cramping,
Mm-hmm.
Oh, yes, sir. For muscle cramping, tonic water is mentioned as possibly helping. How does it help? Is it the quinine?
Bingo, yes, quinine.
The magic ingredient. What is the single best thing that we can do to decrease our chances of those late complications? Weight control, nutrition, regular exercise, or just a combination of all of them?
As somebody who tries very hard to keep off the excess pounds, I can tell you that no single intervention will work. Everybody needs to do all of these.
Excellent. One of our viewers said, I had my vaccinations at the 1-year mark after transplant. I was still on tacrolimus and sirolimus. Now, 3 years later, I am still on tacrolimus and now Jakafi. Do I need to have all of my vaccinations repeated? And if so, if so, when?
Very good question. Sometimes we are forced to give vaccinations and hope for the best because perfection is the enemy of the good. In your case, you're still on systemic immunosuppression. I would wait till the systemic immunosuppression, tacro, sirolimus, are completely stopped, and then actually draw titers, which are looking at the antibodies against these vaccines, and see which vaccines you need reimmunization against. So it's very safe to wait. At this point, that's all I would do. Wait for a year or two, and then specifically revaccinate against the vaccines which have failed to take.
All right. We're nearing the end of our Q&A. I will take a couple more questions. I have chronic graft-versus-host for 11 years now. What does the data say about this? Can I ever become free of chronic GVHD?
Without knowing the specifics of your case, it would be wrong for me to comment. But one consideration is that the underlying inflammation may have actually ceased. And what you're left with is permanent battle scars. And things like, if you have a burn and you get fibrosis, similar features happen after chronic GVHD has affected an organ, you might be left with some permanent sequelae which may not respond to anti-inflammatory therapy. So distinguishing between what is permanently lost versus active graft versus host disease, that would be, I think that's something which needs to be very carefully considered. It is very unusual, as you allude to have active inflammatory graft versus host disease 11 years after transplant. Most likely, it is inactive at this point.
Terrific. Wow, congratulations. We have an 18-year survivor asking a question. She has a few long-term side effects, but she can't find a doctor to address these issues in San Antonio, Texas. Do you have any ideas on where she could look to find centers in San Antonio, Texas?
Well, our colleagues at Methodist Hospital would be very happy to help you out. So we have a very active transplant program there in San Antonio. Please check them out.
And they have a wonderful long-term follow-up or survivorship work group. So I think that sounds like a great idea. I received, and this will be our last question. We are at the end of our presentation. The final question is, I received a stem cell transplant from a 100% matched donor. Why do I have chronic graft versus host disease?
That is a wonderful question. Unfortunately, even with a HLA identical transplant, there's enough immunologic disparity at non-HLA loci, that is at areas which are not tissue matched. There are definitely going to be differences, and these are what will trigger graft versus host disease. So yes, you can have life-threatening graft versus host disease despite a full match. So I'm sorry that this is something that has happened to you, but there is a known mechanism.
On behalf of BMT InfoNet and our partners, I'd like to thank you, Dr. Battiwalla, for your incredible presentation. You have given us so much information, many accolades in the question and the chat boxes, thanking you for your informative presentation. I'd like to thank the audience for your excellent questions and your engagement in this presentation. Please enjoy the rest of the symposium.